Hello students, this is Dr. SJK. So this ENT session is going to be a recall of last year's MRB question. So usually MRB is not an exam with so much hype in my days. Even I didn't write the MRB exam. I wrote my NEET exam, I got my PGC. So at those days, MRB exam is not actual preparation for any students over there. Because if you write MRB exam itself, now you will get a seat. That was the trend at those days. But now it has completely changed because a lot of doctors are coming out from Tamil Nadu who are studying in our state, outside state, and also outside countries. So a lot of doctors are coming with the background of Tamil Nadu. So they are requiring a lot of jobs for Tamil Nadu. So that's why the MRB hype has gone to a certain extent over the last 2 years. So they are saying another MRB exam can be around the corner. So please revise these questions before the next exams. Okay. So we had 2 sessions last time. So we'll discuss questions from both the sessions. The first question from the morning session is: infection of submandibular space is called as Ludwig's angina. Okay. So what are the other options? Quincy is peritonsillar abscess. Instant angina is a necrotizing gingivitis. Ranula is a sublingual retention cyst. Ludwig's angina is a submandibular space infection. What are the other points for Ludwig's angina? It's a submandibular space abscess. It's a mixed bacterial infection, both aerobic and anaerobic infection you could see in this patient. So it occurs mostly in immunocompromised patients, mainly diabetic patients. Rapidly progressive can even lead to respiratory difficulty of stridor. So those patients may need tracheostomy. So treatment is you should do incision and drainage as early as possible. So this is a middle-aged female who had this Ludwig's angina following dental caries. So dental caries can also be an important causative factor for causing Ludwig's angina. Clear? The next question, tripod fracture is. So tripod fracture is nothing but fracture of zygoma because it is a junction of three bony points. So if it is fracture, it looks like a tripod. Okay? So fracture maxilla, fracture mandible. The important point is Dingman classification. Fracture maxilla. If you see trismus, do plating. Nasal bone fracture, do closed reduction. After edema subsides. Okay, so the answer is fracture of zygomas. Look at this X-ray. See, this is an area where 3 bones are coming together. 1, 2, and 3. So this is the site of zygoma prominence. If zygoma has been fractured now, it looks like a tripod. A tripod fracture. Right? Next question, which of the condition does not cause eustachian tube dysfunction? See here, this is middle ear. This is the eustachian tube that connects middle ear with the nasopharynx. So any mass over the nasopharynx can cause eustachian dysfunction, like hypertrophic adenoids, CA nasopharynx, like that. And also some defects over the nasopharynx, like cleft palate or a Down syndrome causing cleft palate, can also cause eustachian tube dysfunction. But otosclerosis is a disease of middle ear where stapes foot plate goes for fixation. So this can't cause eustachian dysfunction, where others can cause eustachian dysfunction. So otosclerosis is a stapes foot plate fixation that is bound to cause only conductive hearing loss, not eustachian dysfunction. All right. So this is an anatomy of eustachian tube. Okay. The nasopharyngeal end. All of the following are true about Bell's palsy except. So Bell's palsy is nothing but element type of facial palsy. So if it's an element type of facial palsy, one side there will be completely affected. Deviation of angle of mouth to the opposite side. Deviation to opposite. So in this patient, it's a right-sided patient, right-sided Bell's palsy. One side is completely loss of frowning, unable to close the mouth, loss of nasolabial fold. Okay, so deviation to the opposite side. So element means complete involvement of one side. UMN means only lower 1/3 palsy. Upper 1/3 has dual nervous supply, so it is not upper. Only lower 1/3 palsy. That is the major difference between UMN and element. So what is the problem? So if it's a Bell's palsy, there should be involvement over the facial canal. So studies are saying that though the Bell's palsy is an idiopathic thing, Bell's palsy means idiopathic, but the studies shows that it could be due to some HSV, herpes simplex virus over facial canal. So that's why the treatment of Bell's palsy is steroids and acyclovir. You could start with steroids. If it is not recovering now, you could also add acyclovir for that patient. So all of the steroids should be started within 24 hours. So there is lesion over the facial canals. And also if you treat adequately for the patient with steroids and antivirals if needed, the patient will recover within 12 weeks. Okay. So hyperacusis occur if the lesion is in the stylomastoid foramen. First of all, Bell's palsy will not happen in the stylomastoid foramen. That is point number 1. Okay. And also, if it happens in the stylomastoid foramen, there will not be hyperacusis. Hyperacusis is due to nerve 2 stapedius. So, if nerve 2 stapedius is to be involved, the lesion should be at the horizontal part of facial nerve or tympanic part of facial nerve. So if it involves only the stylomastoid foramen, only the 5 terminal muscular branches get involved: temporal, zygomatic, buccal, marginal mandibular, cervical. So only these 5 branches will get involved if the lesion is at the stylomastoid foramen. Only facial palsy. No hyperacusis or no loss of taste sensation or no loss of lacrimation. So greatest superficial petrosal nerve, nerve to stapedius, corotemporal nerve, all these nerve will be intact at the lesion of stylomastoid foramen. So in stylomastoid foramen, hyperacusis will not happen. So that is the answer for this question. Clear? So all 3 other options are correct. So next question. So this GSPN will be intact, corotemporal will be intact, nerve to stapedius will be intact. So terminal motor branches will be affected in. So this is the stylomastoid foramen area. Clear? So double target sign is seen in. So other options are nasal myasthenitis, allergionitis, retinopathitis. These are irrelevant options. So double target sign on a white cloth after a trauma for a patient. So traumatic CSF leak patient will be having a double halo sign. Double target sign or halo sign. See here, at center there will be red color blood, At periphery, there will be CSF. Okay. So due to more specific gravity, the blood settles in the middle, CSF settles at the periphery. This is called halo sign or double target sign seen in traumatic CSF aneurysm, not spontaneous CSF aneurysm. It is traumatic CSF aneurysm. Okay. So that completes the 5 questions which were asked at the morning session. Yeah. So totally 4 questions were asked at the afternoon session. So what are those 4 questions? The first question is from here. Hitzelberger sign is seen. So Hitzelberger sign is a typical pathognomonic sign for acoustic neuroma or vestibular schwannoma. Okay. So why other things are given? So in congenital syphilis, hypermobile stapes foot plate, semicircular canal fistula. So in congenital syphilis and hypermobile stapes foot plate, you could see false positive fistula test or Henneberg sign. Is false positive fistula. So in semicircular canal fistula, you will see fistula test positive. Whereas in acoustic neuroma or vestibular schwannoma, you will see Hitzelberger sign positive. What is a Hitzelberger sign? Let me tell you. See, this is the area where the facial nerve and 8th nerve, 7th and 8th nerve enters the temporal bone through the internal auditory meatus, IAM. So if the tumor, which is arising from the vestibular division of the 8th nerve, so the tumor will compress the adjacent nerve of facial nerve, then the cochlear nerve, then the trigeminal nerve. Okay. If the nerve involves cochlea, the patient will be having SNHL and tinnitus. Okay. Look carefully. The nerve, the tumor which is arising from the vestibular division of 8th nerve, first it is compressing the cochlear nerve, causing SNHL and tinnitus. Then it could compress the trigeminal nerve. The first nerve other than the cochlear nerve or vestibular nerve to get involved is trigeminal nerve. There will be loss of corneal reflex. If they ask you which is the first sign other than the vestibular component, is loss of corneal reflex is the first sign of trigeminal involvement. Okay. If facial nerve is involved, only sensory component is affected. Okay. So if there is loss of sensation over posterior superior canal wall, it is called Hitzelberger sign. It is called Hitzelberger sign. Loss of sensation over posterior superior canal wall of the external canal is called Hitzelberger sign because only the sensory nerve of the facial nerve gets affected due to acoustic neuroma or vestibular schwannoma. So that sign is called Hitzelberger sign. Posterior superior canal wall anesthesia. Okay. So merciful anosmia is a classical feature of atrophic dermatitis. In atrophic dermatitis, it is caused by Klebsiella ozonae. It's a bacteria. What will happen? Due to some unhygienic nose, which is getting colonized due to deficiency of vitamin D and estrogen, there will be numerous colonization of bacteria inside the nose that will cause atrophy of turbinates. So due to atrophy of the turbinates, there will be lot of crusting, and also due to atrophy there will be roomy nasal cavity. The crusting will result in a very foul smell, but the patient will not feel the foul smell because due to atrophy there will not be any smell perception for the patient. So there will be anosmia, but the patient can't feel the foul smell of their own body, which is called merciful anosmia. So that description means there is anosmia, but there is a foul smell, but the patient can't feel the foul smell, but other neighbors can feel the foul smell, that is called merciful anosmia. And due to crusting, there will be epistaxis. So, medical management, you should do nasal douching for the patient with chemicidin anti-ozena solution. So, here you will use vitamin D, estradiol, and chloramphenicol. Okay. So, these two deficiency, this chloramphenicol is for antibacterial activity. Surgical treatment, you could close one nostril completely, and after 6 months, next nostril, it is called Young's procedure. If you close both the nostrils at the same time, leaving a small gap in between, it is called modified Young's procedure. So this is creating an anaerobic chamber so that the bacteria will not grow. So creating anaerobic chamber for halting the bacterial growth is called as Young's procedure and modified Young's procedure. That's all about atrophic rhinitis. Okay. Okay. The next question regarding rufford otalgia. So rufford ear pain due to acute tonsillitis is via. See, this is a schematic diagram representing rufford ear pain. So, in case of trigeminal nerve, if there is some pathology over the face, there could be rufford ear pain via trigeminal nerve, because auriculotemporal branch of the mandibular nerve supplies ear, and also trigeminal nerve supplies almost all parts of the face. So any problem over the face can be exerted as a rufford ear pain because both have a common dermatomal supply. Vagus glossopharyngeal nerve, any problem over the pharynx can be exerted as a ear pain because Jacobson branch of glossopharyngeal nerve supplies the middle ear. Then vagus, Arnold branch of vagus supplies the ear, and vagus supplies mainly the larynx. So any problem over the pharynx can be referred as an ear pain. Any problem over the larynx can be referred as an ear pain. This is called secondary otalgia, referred ear pain. So in case of pharyngeal problems like tonsillitis, pharyngeal tumor, or any quinsy, it is due to ninth cranial nerve, which is a glossopharyngeal nerve. Okay, that is the answer. If in case if they would have given it as due to laryngitis or laryngeal cancer, the answer would be 10th cranial nerve. Or if it is due to some problem over the TMJ arthritis over the face, it could be due to 5th cranial nerve. So based on the origin, you should choose this answer. It's a very important question. They have asked a lot of times in NEET also. Next question. So this is quite a controversial question. See, the Calder look procedure is contraindicated. So video neurotomy has nothing to do with Calder look procedure. So age below 17 years, because it is a bone and maxilla has been well developed during the early parts of the lifetime also. So the age is also not a criteria for this patient. Dental cyst is an indication, not a contraindication. So let me explain what the Calder look procedure is. You will do a sublabial incision, and then you will reach the canine fossa. Through canine fossa, you could reach the floor of maxillary sinus. So this is the principle of Caldwell-Look procedure. So if you are having a oroantral fistula, means for time being you may not do a Caldwell-Look procedure, but for oral antral fistula also you could do a Caldwell-Look procedure in a chronic or long run if there is no other possibility. But I can't definitely say this is an answer, but comparing with other options which are not relevant for this question, oroantral fistula can be the right answer for this question. The answer is not final, but this could be the answer because it's quite a controversial question. All options are not giving a clear-cut picture, whereas oroantral fistula has some relevance with the Caldwell-Look procedure. You could choose that answer. Okay. So that's all about the discussion part of the morning and afternoon questions for this MRB recall. So thank you.